Welcome everyone. I'm Dr. Wael Nematallah, Senior Specialist, Medical Imaging Department at Jabal Ahmed Hospital. Today I'm going to show you some of the extrathoracic manifestations in COVID-19. The objective of this short presentation is to present a case of multiple COVID-related diagnoses at the same patient, current explanation for the COVID-related illness, the extrathoracic manifestations of COVID-19, and GIT complications of COVID-19. Our patient is 54 years old, COVID positive patient. He is in ICU, recently experienced acute kidney impairment and distended abdomen with regurgitation on NGT tube. On the 5th day of admission, he developed cold right foot. At the chest X-ray, it demonstrates bibasilar consolidation and peripheral ground glass opacification. CT again demonstrates the bibasilar consolidation and the ground glass opacification peripherally and the small pneumomediastinum. CT angiography was requested for both abdomen and lower limbs because the GIT ischemia or bowel ischemia is suspected. The CT demonstrates massive splenic infarction. It demonstrates also ongoing intestinal obstruction or ileus. However, no any bowel necrosis is seen at this moment, and no major vascular compromise is seen at this moment. Regarding the lower limb, it demonstrates complete absence of flow at the posterior tibial artery and at the tibial-peroneal trunk. At the 3D, again, no flow at the posterior tibial artery and the tibio-peroneal trunk. At the cross section, there is also severe attenuation of the anterior tibial and peroneal arteries with complete absence of flow at the posterior tibial artery, and no any collaterals are seen, denoting the acuteness of the condition. Here, no flow at the posterior tibial. This is the normal one. COVID-19 creates a hypercoagulable state with multi-systemic implications. The current hypothesis is number one, increased interleukin-2 and the tumor necrosis factor alpha-4 may upregulate coagulation and lead to increased prothrombotic profile with elevated risk of thrombotic events. Direct damage to the endothelial cells by the cytokine response to the virus. The presence of angiotensin converting enzyme 2 is also implicated. Severely ill patients may have disseminated intravascular coagulation and elevated D-dimer, which is a common lab finding. One study found that much more venous thromboembolism is seen than the arterial thrombotic events. Hypercoagulability may complicate milder respiratory forms and not only the severe form of the disease. Autopsy examination demonstrated microcirculation damage in patients with COVID-19. About 3/4 of patients of those who died with COVID-19 and 0.6 of survivors met criteria for DIC during a later stage of the disease. Regarding splenic infarction, to date, cases of splenic infarction associated with COVID are rare, probably resulted from arteriolar thrombosis. Incidence is probably underestimated and the finding is often incidental. Regarding the GIT, critically ill patients have a higher incidence of GIT complications. About 3/4 of patients developed at least one GIT complication during their ICU stay. GIT symptoms include pain, nausea, vomiting, diarrhea, and most importantly is loss of appetite. The complications also include hypomotility, which is a complication occurred in about 50% of patients. Ileus and bowel ischemia, which is present in our patient. Ileus may be severe and may precede bowel ischemia. Bowel necrosis may be seen despite patent proximal mesenteric vessels, which is explained on basis of microvessel thrombosis. Hepatobiliary complications include transaminitis, cholecystitis, and pancreatitis. Hepatic infarction could also occur. Other complications include colonic paralytic ileus, which may mimic Ogilvie syndrome or colonic pseudo-obstruction. Adrenal gland infarction could also occur. Mortality is about 40% among patients requiring abdominal surgery. Regarding acute limb ischemia, hypercoagulable state may increase the incidence and extension of native arterial occlusion. The pre-COVID era reported that overall incidence of acute limb ischemia has declined significantly in the past decade, and that the presence of a hypercoagulable state is an uncommon etiology. Acute limb ischemia may have associated venous vascular system involvement. Hypercoagulability was observed in both younger and older patients with a male predilection. Addition of heparin seems to increase the treatment effectiveness and was associated with better survival. Conclusion. Thrombotic disease as a complication of COVID-19 must be suspected by clinicians and recognized and monitored by radiologists. Thrombosis is often the initial manifestation of COVID-2, hence the importance of early diagnosis to avoid complications and reduce morbidity and mortality. COVID-19 related pneumonia is not always the major event or issue in a COVID positive patient. Multiple diagnoses can be simultaneously present in a COVID-19 patient. COVID-19 looks like a systemic illness with great concern should be paid to the extrathoracic effects. More data are required on how COVID-19 and thrombotic disease interact. These are our references, and thank you.